Welcome to the other side of Lucy Letby. In episode 41, we're going to look at the case of baby N. This is 3 attempted murders, and none of them make any sense whatsoever. So, with the prosecution opening statement, we get the usual. Baby N, a boy, was born in June 2016. He was a couple of weeks premature and he was admitted to the neonatal unit. His clinical condition was excellent, of course. The prosecution say there were 3 separate occasions on which Lucy Letby tried to kill him. Baby N had haemophilia. Subsequent investigation found him to have a mild version of the disease. Note, mild version. And children of his age do not bleed for no reason, particularly in the throat, the prosecution say. The prosecution say Lucy Letby used child N's haemophilia as a cover to attack the baby. So we have 3 incidents, each of which constitute, according to these people, an attempted murder. And the first of these incidents was on the 3rd of June, and the baby was born on the 2nd of June. Now we have to recall this is a baby born in excellent condition. So let's see just how excellent the baby's condition was. So the baby was born by cesarean section at 1:42 p.m. and he weighed 1.67 kilos at 34 weeks plus 4 days. So to begin with, he's at least half a kilo lighter than he should be. His APCAR score is Countess of Chester Hospital regular, 9 out of 10 at 1 minute, 9 out of 10 at 5 minutes. And at 2 p.m, Nurse Caroline Oakley records baby N was admitted to the neonatal unit and his problems were prematurity and a clotting disorder. And the clotting disorder is haemophilia. But she should have said prematurity, clotting disorder, and severe intrauterine growth restriction. So at 2:30 p.m, a blood sample is taken and a decision was made not to give the baby vitamin K, IM, which is the proper decision for a baby that has haemophilia, but it should have been given orally. And the observations are intermittent grunting. 1 hour and 30 minutes after birth, the baby has intermittent grunting, plus, plus. And at 3:10, 2 hours or so after the birth, the baby had a major desaturation down to 67% oxygen, lasting 1 minute. And it's recorded by Nurse Caroline Oakley. And the nurse adds, allowed to rest, sounds very mucousy, grunting intermittently, dropped saturations to 67% when upset, temperature being recorded and required 60% oxygen to recover, awaiting blood results before being given vitamin K. And the note is decision made to screen and nil by mouth. So this is, they're presuming, another case of sepsis. And at 6 p.m, barely 4 hours after the baby's born, a chest x-ray shows that baby N likely had an infection. So this is how excellent this baby was when the baby was born. At 6:45, Nurse Oakley said that his temperature was low, but he was recovering. So why in the name of God is the baby's temperature low? There is no reason on earth that a baby who has just been born, premature, low birth weight, should have a low temperature. It is well within the capability of people to keep the temperature of a baby normal by various means. Plastic wraps or bags are used very effectively and they significantly reduce hypothermia, and they're simple thermal care measures. That's what they're called. You have to maintain the delivery room at 26 degrees centigrade. You use warm blankets and pre-warmed surfaces and thermal mattresses, and the use of heated humidified respiratory gas for resuscitation and implementation of skin-to-skin contact when possible. But a combination of a plastic bag or a wrap with a plastic cap and heated humidified gas stabilizes the core body temperature of the baby. And if you don't do those things, if you don't maintain a stable temperature, hypothermia is associated with significant health risks, including increased mortality, increased lung disease, pulmonary hypertension, sepsis, seizures, bleeding into the brain, bleeding into the back of the eye, metabolic disorders, hypoglycemia, hypoxia, metabolic acidosis, and even further on, growth and development issues, and the typical cardiovascular and respiratory effects. Hypothermia will cause bradycardia, tachypnea, apnea, and what do they all add up to? Desaturations. Keeping a baby's body temperature in the normal range after birth is one of the basics of neonatal care, and they apparently can't even do that right. So the excellence of this unit and the excellence of their ability to deliver excellent babies in every circumstance is not really apparent here when they can't even keep the body temperature normal. The proper medical term for desaturation is intermittent hypoxia, which means a drop in blood oxygen level. And these are extremely common. The incidence of them would range from 50% in moderate preterm infants to virtually every baby, over 97% in extremely preterm babies. And in one study that I'll show you, very low birth weight baby, now this baby's not very low birth weight, but very close to it, these saturations occur at a median rate of 60 events per day at 32 weeks post-menstrual age, 41 events per day by week 35. Not all intermittent hypoxic events are apparent. So a lot of them can be brief and don't trigger these machines, and if you don't have someone one-to-one nursing the baby, you're going to miss them. And these intermittent hypoxic events accumulate in their adverse effect on the babies. And this is evidence from animal studies and clinical studies in babies that intermittent hypoxic episodes are associated with injury and poor outcomes. Increased inflammation, our old friend, impaired growth, retinopathy of prematurity, neurodevelopmental impairment, and higher frequencies of intermittent hypoxia events for longer durations, a greater time with hypoxia are associated with increased risks of morbidity and mortality in very early and moderately preterm infants. Hypothermia is associated with hypoxia and respiratory distress syndrome. Infants with hypothermia have a higher rate of respiratory distress syndrome, 86.2% compared to normothermic infants. An enormous leap in incidence associated with letting the temperature go down. And both hypothermia and desaturations are more common in lower gestational age and lower birth weight babies. So even though our baby is almost 35 weeks, it is a low birth weight. And the intermittent hypoxia starts to occur early in the postnatal period. In the median time in one study in a big NICU was 3.5 hours. And the incidence of these intermittent hypoxic episodes gradually rise in extremely low birth weight babies throughout the first 4 weeks of their postnatal life. So rather than get better, they tend to get worse and tend to get more frequent. And therefore, baby N is not in a good place at the moment, and Lucy Letby is yet to show on the scene. And remember, when Caroline Oakley made her note in the record, it was 7:15, and the temperature still hadn't recovered. It was recovering, but it hadn't recovered. The haemophilia is then diagnosed, and at 7:30, only 45 minutes later, Lucy Letby is recorded as starting her night shift. So she hasn't been near the place while all of this has been going on. Letby is a designated nurse, and the shift leader is Melanie Taylor, and another designated nurse was Christopher Booth and Sophie Ellis. And Christopher Booth had 2 babies in room 1, including baby N. And Ellis had 1 in room 2 and 2 in room 3, and Letby had 2 in room 4. 2 babies in transitional care and another baby rooming with her parents. A hell of a lot of babies for that number of nurses. Then we have a lot of nonsense messaging, and we get our first incident. So at 1 a.m, observations are recorded regularly for baby N up to 1 a.m. Well, I would hope so. But at 1:05 a.m, baby N suffered a desaturation. And Nurse Booth, one episode while I was on my break, whereby infant was crying plus plus and not settled. So an infant on a neonatal unit is crying plus plus and not settled. This infant has respiratory distress syndrome. He's half a kilo light, fat. He's 4 weeks early. He's got a chest infection. People are poking needles in him. And he's freezing. He's really cold. And he's crying. And this is supposed to be unusual. And he's not settled. So anybody who's passing this stuff around as evidence of harm is acting irresponsibly. And the baby became dusky in colour, intermittent hypoxia down to 40, and responded to facial oxygen within 1 to 2 minutes. The crying subsided after 30 minutes. The note adds baby N's colour returned to pink perfusion. Now, we don't know who wrote this down, because Nurse Booth said that he wasn't called back from his break, and he also said that he doesn't know who he asked to look after the baby beforehand. So we don't know. Crying subsided after 30 minutes. That could be, and was more than likely, crying for a few minutes, resting, breathing, crying for a few minutes, resting, breathing, etc. And that settled after 30 minutes. But it's going to be passed off by these people as crying continuously for 30 minutes. A preterm neonate with respiratory distress and a chest infection cannot cry for 30 minutes at normal oxygen saturation. They can't do it. And then Nurse Booth says no further episodes observed, but we know that most of the episodes of intermittent hypoxia are not observed. As we say, up to 60 events a day, and increasing over time for the first 4 weeks, not decreasing, and made worse by all the conditions this baby has. And the only true way to measure an intermittent hypoxic event is with an arterial blood gas. But of course, the Countess of Chester Hospital never puts arterial lines into babies. They use pulse oximetry, which isn't accurate. And all the pulse oximetry readings that they're putting into evidence in this trial are not accurate readings. Some of them may be, but not all of them are. And we will see later on in this case an example of that. And the last entry we have in the evidence is at 2:04 a.m. until the handover at 8 p.m. And the handover at 8 p.m. is taken by Nurse Ashley Hudson. who writes down that the baby was breathing fast on handover and was unsettled. So you can bet your bottom dollar that in that period of 6 hours, this baby had other episodes of intermittent hypoxia. And Letby is accused on the basis of that of attempted murder. No one knows who was looking after the baby. Christopher Booth is not called back from his break. He doesn't know what happened. He was told by somebody else, but we don't know who else told him. And this is enough evidence to put into the first indictment in BBN of attempted murder. How, in the name of God, did this get through the CPS? I've no idea. And things don't get any better for the baby, because at 8 p.m. with the handover, again for the night shift of June the 4th now, Christopher Booth is told that the baby had mucky aspirates towards the end of the day shift. So that means the baby's bleeding inside again, and was settled for the rest of the day with minimal aspirates obtained. Aspirates clear with tiny old blood specks. So they're not clear if they have tiny old blood specks. They're blood stained aspirates. That's what they are. And that is at the beginning of June 3rd to the 4th. And Lucy Letby's name is still not mentioned in this at all. The baby seemed to do reasonably well between the 4th of June up to the 14th of June, and we've no information of what happened to the baby in between. No information at all. So I don't know whether that was read out in court, but it's not in this record here. But we become interested in the baby again when the 14th of June comes along, because Lucy Letby is a designated nurse for BBN on the day shift of June the 14th. At 7:40 a.m. BBN takes on a feed of express breast milk, and 8 a.m. Lucy Letby notes at the handover. And Letby rightly complains that a colleague left behind a dirty bottle that she had to clean. Just another example of what goes on in this place. The baby they were still checking the temperature was normal, and Letby notes that the man feeding expressed breast milk via own bottle, completing more than required volumes, repeat, and that the baby was still jaundiced and that the trend was downwards, but it had not reached 50% yet. Otherwise, the baby was ready for home. It appears then that Letby's day shift went uneventfully, but on the 15th of June at 1 a.m, so we're into the night shift where Letby is not on, Jennifer Jones Keys, just after 1 a.m. on June 15, records that baby N had become very unsettled and was pale, mottled and veiny with slight abdominal distension. And blood tests were taken for analysis and further observations are taken. So you can bet your bottom dollar that baby N is now coming in for late onset sepsis. That's the first thing that would have to spring to mind, and that's why they've done the tests for analysis. And in the meantime, at 5:10 a.m. in the morning, Letby's colleague texts her and says, "I wouldn't come in if I was you." And Letby goes, "Why?" And she says, 5 admissions, 1 vent. Baby N screened, looks like shit. 6 a.m. Jennifer Jones Keys notes, "Baby looked worse this morning and the capillary refill time after 3 seconds. So the baby is declining now, not even perfusing right. The people around it are noticing that the baby is deteriorating. And Letby isn't even on the ward yet. But at 7:15, the baby had another intermittent hypoxic event. And Jennifer Jones Keys records at 7:15 baby crying and dropped saturations as seen by neonatal nurse Lucy Letby. The nurse adds baby Anne was given 100% oxygen support by a doctor and then transferred into room 1. And then we get another very interesting note that we have a reciting of the nasogastric tube. So the baby had a nasogastric tube. When was that put in? And how long had it been in? No record of that. But it says nasogastric tube recited in the right nostril with an acid reaction. So that's just to make sure they haven't put it in the lung. And at handover, baby dropped saturations and required neopuff care handed over to neonatal nurse Lucy Letby. Care handed over when this was happening. And then we get this Lucy Letby saying infant transferred to nursery 1 on handover. So transferred to her in this condition, mottled, desaturating, requiring neopuff and oxygen, cold to touch. Cold to touch. And then she writes a record of 1:53 p.m. for care at 9 a.m. Unable to intubate, fresh blood noted in mouth and yielded via suction. So the baby, having looked like shit the night before, having been clearly deteriorating with no action taken, has now moved from being ready to go home to needing intubation, which they were unable to do. And they say fresh blood noted in mouth and yielded via suction. Now these people are going to go on to say that Lucy Letby did this to this baby with the nasogastric tube. Darry Evans is going to go on to say that Lucy Letby stabbed the baby's throat with the nasogastric tube or some other implement. He wasn't there, he didn't see it, and he is failing to acknowledge the fact that the baby was clearly deteriorating in the 24 hours, if not longer, before this. So let's just have a little look at nasogastric tubes and what they're capable of doing. And remember, we're talking about a hospital that's full of shit, literally, that has pathogenic pseudomonas at the least floating about the place. We're not talking about a well cared for, well oiled machine where everything is kept clean, everything is kept tidy and neat. Lucy Letby has to clean up a bottle that was left uncleaned, and she was quite rightly annoyed about that. It shouldn't be surprising to know that nasogastric tubes are very risky when it comes to infection in preterms and sick infants in general. And in one study that was a quite big study, 89% of nasogastric tubes yielded more than 1,000 colony forming units. That is a high amount of colony forming units, and a colony forming unit is simply a measurement of the number of bacteria that is sufficient to cause an infection or indeed sepsis. 5 colony forming units is all it takes to create an infection, and these things had 89% of them yielded more than 1,000. And in this study, the density of the bacteria was found even after the first day of use, and biofilm formation on nasogastric tubes occurred within 24 hours of placement. And one of the top dogs for creating biofilm is, of course, Pseudomonas. And Pseudomonas is exactly the same as all the other bacteria that can create these colony forming units. They can do it within 24 hours. And the biofilm formation then serves as a habitat for other potentially pathogenic bacteria. And the studies have shown that nasogastric tubes are frequently colonized with various bacteria, including Enterobacter, Klebsiella, Staphylococcus, and Streptococcus. and it's particularly frequently found in the oropharynx of patients with NG tubes. And what are we going to be doing over the rest of the podcast series on BBN? We're going to be talking about the oropharynx in a baby. So we have a very high probability, 89%, that the NG tube that was in the baby running down its throat through the oropharynx was carrying biofilm and other bacteria. But they didn't check for that because it isn't in the evidence. And one of the bacteria that was grown in the study that looked at the colonization of the NG tubes was Streptococcus. And Streptococcus is a well-known bacteria that causes epiglottitis, which is an infection and inflammation of the little fold of skin that closes over the trachea to stop food going down into the lungs. So again, any doctor looking at this with any kind of honesty would say we have evidence here of late onset sepsis 7 days after the baby is born, and we have a filthy hospital and an NG tube permanently in, which can harbour up to 1,000 colony forming units, create biofilm and allow other bacteria to grow in it as well. But we're not going to put any of that medicine and science into the evidence. We're going to blame Lucy Letby. That is basically what we're going to do. Remember, we've also used suction as well to remove the fresh blood apparent in this baby during the attempt to intubate it. We're going to blame that on Lucy Letby as well. Even though we're using very hard plastic on tissues in this baby's mouth that are really not much stronger than the skin of a jelly and can bleed with the slightest trauma, particularly in preterm babies and possibly in babies who have haemophilia. The prosecution in this trial said that the baby had mild haemophilia. Well, haemophilia, and we'll talk about haemophilia, but haemophilia is mild, moderate, or severe, depending on the amount of the clotting factor that should be present, isn't present. And the baby has already problems with clotting due simply to its immaturity. Now, the clotting mechanism in preterm babies is kind of compensated for in many ways, but they are still at risk of spontaneous bleeding or bleeding with traumatic medical interventions. And in the study on the oropharynx, that's the part we're talking about here, in preterm neonates with moderate haemophilia, they can experience spontaneous bleeding from the mouth and the oropharynx, even though the prosecution said they cannot. And oral and nasal bleeding are common events in the first 2 years of life for infants with haemophilia. 41.3% of babies with haemophilia experienced oral nasal bleeding episodes, and they accounted for 14% of all the bleeds in the study. They can have severe bleeds following injury and occasional spontaneous bleeds, and even the spontaneous bleeds can turn out to become severe. And this is further complicated by the physiological immaturity, as we said, in the hemostasis, the bit of the body that stops this bleeding out, and susceptibility to continued bleeding because the clots that the babies form are friable. They're not very solid, so they'll just continue bleeding. They don't work as well as a fully mature clot would work. And all of these medical interventions, suction, intubations, nasogastric tubes, all of these things can trigger bleeding in these babies. But the prosecution said that they couldn't. Many people are going to disagree with that. And again, it's another example of false medical statements going into evidence in this trial. But with all of these events and all of these possibilities, Lucy Letby is going to get the blame, even though no one seen her do anything to the baby. No one witnessed her harm the baby. No one witnessed her do anything other than what she was supposed to do or what she was trained to do. Darby Evans, the chief witness in this trial, who has already publicly withdrawn one of his fantastical causes of death, was not present and did not witness Letby doing anything. But he's going to say that she did something. And he's going to claim that it is a valid medical opinion. Well, I've just given you a valid medical opinion based on studies, based on science, based on what we know. The opinions that Darby Evans gives are based on what he thinks he knows or what he wants to know. As Justice Jackson said, he made no effort to inform himself of other people's opinions. And interestingly, Letby says in one of her text messages that she apologized to a doctor, and she said that, sorry if I was off during the intubation. I like things to be tidy and calm. Well, as much as possible. Exactly. That's exactly what you want. Everything to hand and everybody calm. But it doesn't sound like that's what was going on during the failed attempt to intubate this baby for an unknown reason so far. And then she said, no more bleeding, thankfully. And the 15th of June continues on with Letby recording. Baby N had a profound saturation. Infant became apneic with DSAT to 44% and heart rate fell. Fresh blood noted from the mouth. Minutes later, a number of senior medics were crash bleeped to attend the child. Then Letby carries on in her note to say that there was difficulty intubating the baby and that 2 doctors had failed to obtain a secure airway. And not only that, 2 consultants from the anaesthetic team were called to help, but they also had difficulty fitting an ET tube. And the people in the Countess of Chester Hospital, who should never have taken a baby like this in the first place, a baby with half a kilo below weight, severe intrauterine growth restriction, preterm with haemophilia in a level 2 unit. And they cannot intubate it. 4 of them can't intubate the baby. They've decided that they're going to transfer the baby, and Letby hangs about until the baby is shipped out to the proper hospital. And the baby's shipped out to the proper hospital, where he remains for 2 weeks. 7:40 p.m. June 15 shows there was a further profound desaturation in baby N with a colour loss that required nail puffing because they'd failed to intubate the baby. Of course, he's going to have a profound desaturation. They have not secured the airway. And at 10 to 8, the baby boy required resuscitation and a number of doses of adrenaline. He eventually stabilised, and Miss Letby said in a message to a colleague who can't be named for legal reasons that baby N's parents were present and they had the little boy christened. So they were really worried about this little boy. And it's interesting as well that in one of the messages, she asked Dr. A, the treacherous, lecherous Dr. A, what he thought the cause of baby N's bleed was. And he said, I think there will be a hemangioma or collection. So he's talking about these unformed clots that are building up behind the little epiglottis, the little fold of skin, which we'll talk about. And he says if it was epiglottitis, that's infection, his CRP should have been higher because he was starting to become unwell. CRP or C-reactive protein, or as we've talked about before, acute phase proteins, are useless in diagnosing infection in preterm babies. They're a waste of time. You're maybe much better using the blood that you're wasting on the CRP to take a bigger sample and catch the low colony count infections that you're missing all the time. But we don't have any notice here of a throat swab or any attempt to find bacteria in the actual local area. Now, as I said, the baby was shipped out to Alderhay and kept for 2 weeks. So whatever happened in Alderhay, we need to get the records for that and find out what they diagnosed and what they did. And we will find out more about what happened on this particular day as well. And then just briefly to finish this introduction to this mess, the mother's statement, she said that baby Anne had haemophilia, and on June the 15th, the parents were informed that the baby boy had had a bleed. The parents were informed to attend hospital as soon as possible. Baby Anne was in intensive care, and on arrival, Lucy Letby was there with other people. Baby Anne had 2 collapses that day. The parents were told to go out and get some fresh air, and while they were out, baby Anne had a second collapse, and a spur of the moment baptism took place. Lucy Letby stayed beyond the end of her shift, which is not uncommon for people who care about what they do, and baby Anne was transferred to Alderhay Hospital, where he recovered quickly over the following couple of days. But he didn't stay for a couple of days, he stayed for a couple of weeks. And in the father's statement, he said that he was shocked when he came into the ward when he was called from work, when the baby collapsed, because they had let the baby become sick, and they hadn't reacted, in my opinion, to the signs that were clearly there the night before on the 14th. And he said he remembers being confused and thinking, what's wrong with him? And no one told us what was happening or why. This is the Countess of Chester Hospital. This is what they're talking about at the Thirlwell inquiry. Will any of these lawyers in the Thirlwell inquiry ask any of these consultants why they didn't tell the parents what was happening? Why their baby was so sick? Because they're supposed to. And he said after going outside for a bite to eat, they returned to the neonatal unit and found the blinds were down. And a staff member at reception, not a medic, told them that baby Anne was really unwell. This is just awful stuff. Someone came into the maternity room, where baby Anne's mother was staying with the father. And the staff member said, you'd better come. He's really ill this time. Upon their arrival to the intensive treatment unit, resuscitation efforts were being administered to baby Anne. The father said he couldn't watch what was going on. And staff at Alderhay's Children's Hospital were among the staff members in the room. And the staff at Alderhay's Children's Hospital had to come from Alderhay to the Countess of Chester Hospital to intubate the baby. Pediatrician or the neonatologist that turned up was able to intubate the baby when all 4 of the other ones had failed to do it. But he didn't come on his own. He also came with an ENT surgeon. So why would you bring an ENT surgeon with you? Someone had to tell them when they were asking for help from Alderhay that they needed to bring an ENT surgeon, because they were likely going to have to do a tracheostomy or some kind of surgical procedure to overcome this blockage in the throat. That blockage in the throat was not there because Lucy Letby hit the back of the throat with a nasogastric tube. That wasn't the reason that people couldn't intubate the baby. The baby had swelling. In my opinion, it had epiglottitis infection, and the infection had come from the crap that was on the nasogastric tube for God knows how long it was in, but we know it was changed when the baby was transferred back to room 1. But there's no mention of it in the prosecution opening statement that there was an NG tube, and there's no mention of the fact that NG tubes are as dangerous as I've just said, particularly in this place. And the father confirms in his statement that baby Ann was taken to Alderhay, where he stayed for a couple of weeks before going home. So he never even went back to the Countess of Chester Hospital. He remained in Alderhay for the rest of that time. That's the third apparent attempted murder by Lucy Letby. And the father goes on to say, when home, the parents noticed baby Ann had twitches and later spasms, and at one point was not breathing. He was taken to the Countess of Chester Hospital and transferred again to Alderhay, where he stayed for another 1 to 2 weeks. One of the problems with haemophilia, unfortunately, and with infection, and with RDS, and with prematurity, and with all the other things that the baby had, is bleeding into the brain. And this can be mild or severe. So we don't know, because there's no more mention of baby Ann, what condition the poor child is in. But I would say, from my opinion, that this baby should never, ever have been in the Countess of Chester Hospital. And the Countess of Chester Hospital consultants are trying to tell the world that they were worried about the rise in mortality in their unit. But yet they kept on taking these inappropriately sick children. Why did they do that? Who was making the decision to admit these children? I don't understand that. There has to be a consultant's name on every admission. There has to be communication from the point of deciding where the baby's going to go to when the baby gets there. In everything that we have read so far in the trial of baby Ann, I haven't heard a consultant's name mentioned. Now, we're going to get to the evidence of the doctors and the nurses who were there during this time, and we're going to find that the evidence of the doctors and the nurses differ from what the prosecution said. The driver of this whole thing is Dowie Evans, who claimed that he knew somehow, mystically, spectrally, he knew that Lucy Letby had injured this child with a nasogastric tube or something else. That's the level of evidence that was used to convict this girl. Nobody's seen her do that. There is no evidence that she did that. This baby, like all the other babies in the Countess of Chester Hospital, in my medical opinion, suffered from a systemic failure on multiple levels. They weren't able to intubate this baby, and they're going to go on to explain why they weren't able to do that. So we'll leave this episode here. Letby was found not guilty for the first 2 alleged attempts and was found guilty for the third one. And we'll look at how statements change, how stories change, and how the charge was shaped against her in the next episode. So I hope you picked up some useful information from that, and I'll see you in the next episode. Bye.